Good morning, everyone. We're just going to give a few minutes here for some more people to join. So if everyone just wants to hang tight, we'll be starting up in a few seconds here. Okay, I think we are good to get started. All right, welcome everyone. Thank you for joining us for Redefining Pharmacy, Safer Care, Expanded Practice, and Global Impact from Accreditation Canada. I know this is a group that's somewhat from around the world, so I think just to start, maybe as a bit of an icebreaker, if everyone just wants to put in the chat where you're coming from, it would be great to see sort of that sort of engagement, where everybody's coming from. Let everybody know sort of where we have people at the moment. To start things off, I want to say thank you, obviously, to you, the participants who are joining us. This wouldn't be possible if you guys didn't come out and have an interest in what we're presenting on today. I also want to thank our wonderful panelists for taking the time and sharing their expertise with us. And lastly, I'm going to thank Accreditation Canada for hosting. All right. It is also important. We're just going to take a few minutes in the effort of gratitude to acknowledge and be thankful for the diverse and Indigenous peoples whose marks in this territory. Sorry, give me a second. We acknowledge and thank the diverse Indigenous peoples whose presence marks the territory on which peoples of the world now gather. I personally am presenting from a space of the Haudenosaunee, the Anishinaabe, and the Algonquin people. All right. Some of you may not be aware of who Accreditation Canada is. Um, for you, those of you who don't, Accreditation Canada is a nonprofit organization that empowers health and social service organizations to meet both national and global standards. By offering innovative, tailored programs that address local needs, it facilitates the continuous improvement of quality and safety and care. Accreditation Canada assessment programs and services support the delivery of safe, high quality care. Our specialized accreditation and certification programs support safe, high quality care for specific populations, health conditions, and health professionals. Okay, before we get started, just a couple housekeeping things. This webinar is scheduled for 90 minutes, 60 for the presentation and 30 for questions afterwards. There's two buttons at the bottom of your screen. The first is the chat button. Feel free to have discussions in there, obviously. We also have some of our team members in that chat as well, in case you have any issues or have any questions about Accreditation Canada that you'd like to pose to us. With regards to questions for the panelists, there is the Q&A button. In that section, we're going to be gathering up questions to be asking during that 30-minute question period. So again, feel free to fire off questions. We're going to gather them up and try to answer as many as possible. Just thinking about one question that always comes up. We will be recording this webinar. Give us about a week or so. It will be delivered to you via email once we sort of have everything sorted out. But yeah, it is being recorded and it will be sent out to you after the presentation. All right, so let's get to our panelists. We are very grateful to have Dr. Regis Valancourt, who is the President of Pharmacy Affairs at BC Pharma and serves as the chair of the HSO Medical Management Technical Committee. With a distinguishing career spanning 25 years as a military pharmacist, reaching the rank of Lieutenant Colonel, Dr. Valancourt subsequently held the position of Director of Pharmacy at the Children's Hospital of Eastern Ontario from 2005 to 2021. Currently, he is leading the HSO's Medical Management Technical Committee in the development of the upcoming revised standard. Sarah Ingram is a pharmacist and educator from Toronto whose work spans the full spectrum of pharmacy practice, from teaching and clinical care to patient safety and regulatory leadership. As an assistant professor in the teaching stream at the University of Toronto's Leslie Dan Faculty of Medicine, Sarah is committed to preparing pharmacists with the skills they need to succeed. She has made significant contributions to the medication reconciliation process, bringing her expertise to clinical practice at the University Health Network and to patient safety initiatives at the provincial, national, and international levels. Sarah has also held leadership roles in governance and regulation at the Ontario College of Pharmacists, further broadening her impact on the profession. Sarah Dunn has been a family caregiver for over 15 years. As an advocate for her parents and autistic son, she has experiences in cancer care, primary care, emergency and long-term care. In addition to being a patient surveyor with Accreditation Canada, she has contributed to several working groups as a patient partner and has also been supporting the training of new surveyors. Professionally, Susan has been a patient and public engagement advisor with Nova Scotia Health. A strategic focus of her work for the past 15 years has been building internal capacities to involve patients, families, and communities in meaningful decision-making and priority-setting processes. At this time, Susan has delivered workshops on patient and public engagement to 2,000 learners. She has led development of patients, family, and public advisory committees, developed patient engagement planning and volunteer recruitment tools, was logistical team lead and content developer for province-wide conversation on the health status of Nova Scotians, provided advisory and practical support to corporate and local engagement initiatives, and is part of the AIP2 award-winning team of engagement professionals. And without any further ado, I'm going to pass it over to Susan to start her presentation.
Thanks so much, Andy, and it is a great pleasure to be here today. I'm just going to share my screen so you'll be able to follow along in my presentation. So I'm doing something today that I don't always do, and that's talk about my personal healthcare experience. And I was so pleased to be invited to talk about the impact that a pharmacist can have in patients and families' lives when they're able to expand their scope of practice and offer some ability to prescribe medications and help people with their healthcare needs. So these are actual photos of actual prescriptions that pharmacists have given. Pharmacists have started prescribing in Nova Scotia since 2011, so a little bit of experience in this world. And again, it's made such a difference to me and my family. So on the left-hand side of the screen, you can see two little containers. I experience eczema from time to time, and although that is a minor ailment, of course, even small breaks in the skin can be more troublesome. I've had cellulitis more than once. Sometimes that's meant I had to go to the hospital for IV antibiotics. So I'm perhaps very aware of even small breaks in the skin, in addition to just how uncomfortable that eczema can be. In the middle part of the screen, you can see a screenshot from a great option that we have here in Nova Scotia. We've all been getting used to pharmacies and pharmacists providing flu vaccines, COVID vaccines, etc. And I think that's probably how most of us in Nova Scotia got introduced to the notion of pharmacists providing more than their typical professional advice around medications. And for us, this is incredibly convenient. We can go online, we can book these appointments. It can be with our local pharmacist that we know, it could be with any pharmacist. So this is incredibly convenient from a patient perspective to be able to go and choose a time and location that's convenient to us. And on the right-hand side of the screen is a picture of my mother's puffer. So my mom is 86, and in the fall she came down with COVID. So she was obviously incredibly concerned about this. due to her age and the fact that she's had pneumonia more than once in her lifetime. So pharmacists in Nova Scotia could prescribe what we nicknamed the COVID puffer, this special puffer that was given to people who came down with COVID. And so this was, again, hugely beneficial, just contacting the pharmacist, even with a home rapid test, and she could get this puffer. So she got her care that she needed faster, more convenient, and she didn't need to wait to try to get an appointment with her family doctor. And I think what's particularly important when we think about perhaps some of our seniors who are always used to going to their doctors to getting prescriptions or getting care for minor ailments. So this is hugely beneficial for everyone. And I don't think she would contact her family doctor for a flu shot anymore. She would just go directly to the pharmacist. So these are some more ways to think about the benefits of the pharmacists and their expanded scope. So on the left-hand side of the screen is an image of, again, some of these minor conditions that pharmacists in Nova Scotia are now able to support people in. Also important to acknowledge that pharmacists are expanding their ability to treat and support patients. So in Nova Scotia, they're even being involved in various aspects of supporting chronic disease management. So I think this is not just a nice to have option. I think it's a necessary option because not everyone has a family doctor or a nurse practitioner or access to reliable primary health care. Sometimes going to walk-in clinics is not always convenient. So having the pharmacists able to support patients and families is incredibly important. I'm fortunate, I have an amazing family doctor, but I think, again, having that option to see a pharmacist, that really maximizes healthcare resources. As we know, there's pressure on primary healthcare everywhere. I think this also relieves pressures on emergency departments and those very important primary healthcare services. You know, and pharmacists are people that we trust. They are a trusted profession, and people might already have this trusting relationship with their local pharmacist. So this is just one more thing that a pharmacist can do, and the pharmacists know you. So I think that also helps give people increased comfort to perhaps share some of their other concerns. And again, a huge thing, it is timely access. I think getting care sooner for things that are small things really prevents it from becoming a big thing. So, you know, for me, I think that pharmacists really improve the quality of care that people do receive. And, you know, I could take it so far as to say that it improves the quality of our life if we're not being concerned about some of these minor ailments that we might have. And they're another option. And I think from a patient family people-centered care perspective, having options that really support people in their needs at a place and a time that works for them just is a huge benefit. So I'm obviously a big fan of pharmacists having an expanded scope of practice. Of course, recognizing it's different in various provinces, and fortunate that we've been having this here in Nova Scotia since 2011. Thanks so much, and I'll pass it back to Andy.
Thanks, Susan. That was great. So I'm going to pass it now along to Sarah. Sarah, thank you for joining us. It's all yours.
Thank you very much. I'll start by sharing my presentation as well, and hello to everyone on the call here. Oh, on a moment. Okay, there we go. Okay, everyone can see my screen. Okay, so, oh, a moment. Forgive me, my screen has... Okay. I just want to verify, is my screen visible?
It is, Sarah. It
It
looks
is,
good.
okay. It's just it has changed on my screen personally.
So we're seeing the title slide right now, the blue.
Okay. And let me, forgive me, just one moment. Okay. For some reason it's very small on mine, but we'll have to, it's okay. We can work with that. So hello everybody, and thank you so much for to Susan for that, coming at this from a patient perspective. I want to bring it from that patient perspective and bring it also to looking at redefining pharmacy, so the safer care, expanded practice, and global impact from a consistency, competency, and care perspective as a pharmacist. It's sorry, one moment. I'm just going to stop the sharing and then I'm going to restart it because I can't seem to advance my slides. So forgive me for a moment. Okay. There we go. Okay, so as we talk about the evolving role of the pharmacist, traditionally we've seen as pharmacists are focused on safety, dispensing, medication management. Over time, we have now seen that they are moving into different realms. So looking at prescribing, assessing, collaborating, immunizing, and these, the breadth of the skills and the services that are being provided by pharmacists does vary a lot across the country, province to province, and internationally as well. But today we're going to focus on what's going on in Canada, but I know there are some other participants on the call who may be calling in from other areas of the world. Pharmacists tend to be seen as a very trusted profession, and they're accessible, they're highly trained. But it's really important that as these skills and services evolve, that also the system structures and safeguards must evolve with them. And this includes various different areas. So first, the educational perspective, ensuring that pharmacy students, as they're coming through, do have the right education, background, skills to be able to function effectively in this new healthcare setting, because really it's evolving from what used to be done historically in pharmacy. We also have to ensure from a regulatory perspective that we are maintaining those the public safety standards. So as we are broadening the scope, that there are the right checks and balances and quality assurance present. Then also, if we look at the patient care perspective, which Susan very nicely touched upon, that this really, there's a lot of increased value from having access to trusted, timely care from a pharmacist. It's often someone you know. They're easy to access, and this can be a wonderful thing, but also with the variability between provinces. For example, someone traveling between different areas of Canada may find that a service they can access in one province may not be available in another. So this can create a certain degree of the variability, but also not sure exactly what is available where. Pharmacists really are positioned, but not automatically prepared to deliver more. So this is why these three areas we do need to focus on as the role of the pharmacist evolves. And, only if practice, education, and policy evolve together are we going to have a successful and structured program so that we can have that consistency, have that access to care, which is really key in today's healthcare setting. So why now? So I mean, right now we have both, the pressure and the opportunity. Often situations where there is a need does present a certain, we do need to expand, see what options are available, but it also is an opportunity to step forward. During the pandemic, we first saw that, and I think coming out of that, we do see still a significant amount of system strain. There's a lot of primary care gaps. The emergency wait times are increasing. We have an aging population in need of care. And we don't have a lot of access to family doctors. There's not sufficient to cover our population needs. There's patient need more timely and just simpler access to care. So there's not that many steps and appointments and delays to accessing the care that they need, so that, it can be treated at a time when it is far less likely to become a further problem, rather than having to wait and sometimes jump through several hoops to get to the care that they need. Across Canada and internationally, different key stakeholders have begun to explore different solutions to fill this primary healthcare gap. And I think having the pharmacists step up, as well as other healthcare providers, to fill this gap is something that we see as part of this healthcare evolution. And, it's important to see expanded pharmacy practice as a health system solution, not just a professional evolution, because this is part of, our healthcare system. We see the landscape changing. So with this expanded role of pharmacists, we do see this is a potential solution to some of these system strains that have become more evident over time. When we look at our Canadian patchwork, so the pharmacist roles and the patient experience can change dramatically across provincial lines. With healthcare being a provincial responsibility in Canada, provinces can adapt to serve their constituents. So it's great in that way that they have flexibility to adapt to the, to the people living in those provinces, but it also creates some inconsistency of service models across Canada. When we look at the jurisdictional inconsistency, so what care patients can access in different provinces, how pharmacists are trained. Now, while there is there's a national pharmacist accreditation system, there's also within each province there may be different additional regulations that need to be met. So that's where both initially and then also with continuing education, the standards around how pharmacists achieve and maintain licensing may differ province to province. The relationships with key stakeholders, depending on who is involved in this decision making. Also, the variability of funding and reimbursement models across jurisdictions. These all lead to variability and differences in services that are available to patients across Canada. So this is something that we're seeing now, that although there is advancement in all areas in Canada, it does vary province to province. All right. So yeah, this is more provided. So this just gives you an idea. I recognize that is a very small print. And, as soon as you put together a table like this right now, given the way that things are changing, it may have, it changes within 24 hours sometimes, depending on the way things are moving forward. But it gives you an idea that across Canada, most provinces have already engaged in broadening the scope of practice for pharmacists. They may be ailment-based, they may be more broadly based, they may include specifics, they may be more therapeutics. And they include also other things outside of the minor ailments prescribing, to lab test authority, vaccination and injection authority, and some also have some chronic management programs available to patients living in those provinces. So this just gives you an idea of the sort of responsibilities and scope that pharmacists in those particular provinces are currently practicing and what's available to patients. So one thing about, this expanded scope of practice is that competence requires preparation. So expanded scope does not always, it may in many cases already be automatic readiness, but not always, depending on the scope and the area. So, pharmacy faculties and educational programs, in addition to therapeutic and practical knowledge, have to have increased curriculum focus on various different areas. So beyond, it was previously there, we're now looking more at the advanced clinical reasoning, diagnostic exclusion, so the sort of red flags, clinical communications and documentation of interventions, because if it's not written down, it's hard to tell if it happened or not. So while documentation has always been key, this is something now that is expanded even further to ensure that those clinical interventions are documented properly. Risk recognition and decision making. So as we are expanding the scope, these are things to keep in mind. It's really important to recognize that pharmacists play an important and integral role in patient care, but may not be the best provider in every case. As a specialist or, various other roles within the healthcare system. So collaboration really matters here. They are a key player in this in the patient care setting, but it is really important to collaborate with other healthcare providers as well. And clinical training is important, but the pharmacist has a number of tasks. So it is important to look at the other aspects that may influence their ability to provide this care, including protected time, having the effective documentation system, looking at quality assurance to ensure pharmacists can make safe and appropriate decisions in the healthcare setting. So when we look at, expanded scope and balancing access and safety. So from a regulatory perspective, we want to it enables access when safeguards exist. This requires ongoing training, documentation, and accountability. And we really seek better system integration to reduce fragmentation. So there's a lot of focus on working with the government to integrate legislative changes into safer practice. When we look at the patient prong, we're looking at the patient perspective, looking at someone comes in, they're expecting timely care from a capable provider. They may be unfamiliar with the professional scope boundaries between what a pharmacist in either a particular province or area may be able to do versus, say, visiting a family physician, an emergency department, a nurse practitioner. It assumes providers are communicating with each other, which may or may not be the case, but that's an area where I think the focus of communication needs to continue to grow. The patient is a person who feels the risk when care is disconnected. This is why it's really important to have that point of access where the pharmacist is there to provide the care, but it is important to communicate and collaborate. And patients really live at the intersection of our system design decisions. So creating good system design from the get-go is really key. The pharmacist's perspective, on the other hand, must deliver high-quality care in real-world conditions. They face rising responsibility without always having the clear authority or infrastructure to practice effectively, as we talked about with that protected time and documentation. Even sometimes physical limitations of the space. Pharmacy scope expansion is often linked to a place of practice, so a community pharmacy or a clinic versus professional designation, where we see the differences between what a community pharmacist can do, what a hospital pharmacist can do, what outpatient clinics are able to provide depending on their location. And the pharmacist also needs to create, maintain, and share records that increase collaboration. So there's a lot of documentation that needs to go so that they can contribute to the overall care of the patient by the healthcare team. So this is, as I mentioned, the communication is a missing link. So the key risk is this care fragmentation between providers and the different healthcare settings. So pharmacy services can often be the invisible piece to the others on the care team. So what you discuss with your pharmacist may not always be communicated to your family doctor and may not be available, say, if you presented to an emergency department. So what's really needed here is, as the scope evolves, focus on shared records in an accessible and readable format, clear and concise documentation, the interprofessional trust and established communication channels, and the expanded roles really require expanded connection rather than this siloed care that can sometimes occur. So global lessons, they're in UK, Ireland, Australia, pharmacist prescribing is part of practice. These models do emphasize that integration into primary care, the longitudinal patient relationships, and shared records and accountability. So Canada really must adapt thoughtfully given its unique healthcare systems to ensure it meets the required needs from a multifaceted perspective. So getting it right, we need to focus on the national education and practice standards, building on an existing strong base. There's a lot in place, but to expand into this as the scope expands as well. Consistent training and evaluation for ongoing quality assurance. We need the regulatory support grounded in the risk review and evidence-based decision-making, the system design that links pharmacists to the rest of the patient care team, and builds a stronger relationship between care providers. So closing thoughts, in this strain system, pharmacists are really part of the solution. Regulators and educators must align scope with safety, and so that there's increased consistency across Canadian jurisdictions. So this can help really improve access to services and public understanding of what care is available where, so that it's a lot more effective, and that these services can be, what is where. Pharmacy really has the reach and readiness to shape safer, smarter care, not just in Canada, but globally. So for system success, there needs to be an alignment between that public need, the professional ability, and safety. So in my presentation, there are some references, but that's it for me. So I hope I provided you a little bit more background on how these three pieces come together in order for pharmacists, to be able to expand scope in a way that is safe, effective, and highlights their competency, and so that they can fill that gap in the healthcare system. And on that, I will pass it back to you. And I believe it goes back to Andy now.
Yeah, thanks, Sarah. That was great. That was fantastic. Susan obviously presented on her perspective of how useful having a pharmacist in her community that she can have direct access to, and you sort of pointed out that it's not all perfect. There's lots of things that need to be considered to make that absolutely applicable and work well. A quick note, I apologize. The chat wasn't working when we first started up. It is working now. So again, I encourage you to use the chat to have discussions and to bring up points of interest. There are a couple things already in there that are of interest. And while Dr. Regis Valancourt gets set up, maybe again we can try this where you can do a quick shout out from where you're coming from today. But what I'm going to do is I'm going to pass it off to Dr. Regis to get things set up and get things rolling. Thanks again.
And I think you should be able to see my screen at this point.
Nope, we lost it. You're going to have to, you lost your presentation. We're flipped over to another screen here.
Okay, sorry. And I thought I was ready.
We did have it, and then it sort of rolled over to something. So let's see what we've got. Algeria, Tanzania, Toronto, Kuwait. This is great. Edmonton, Newfoundland, Dominican Republic. There we go.
You see my screen properly?
We got it now, Dr. Cole.
Okay, so I'll start. So I'm a pharmacist. I've been a pharmacist for 43 years. And I had the privilege for the last 23 years to be a surveyor for Accreditation Canada. And I'm now currently the chair of the Technical Committee on Medication Management. And to give you perspective, what it means to be a surveyor. So twice a year, usually 1 week, 2 weeks per year, basically you go and do an accreditation survey. And I've done across Canada the accreditation survey, but also had the privilege to go to other countries. I went to Belgium to do a few survey, and then Qatar. And Qatar, I was doing the medication survey, medication standard for community pharmacy. So let me talk about, sorry. So there's two different organizations that are kind of linked. There's Health Standard Organization, which create the standards altogether, and which the technical chairs report to. And there's Accreditation Canada, which basically does the assessment of the standard on site. And I had the privilege to work with both environment because I've been the chair of technical and drafting the standard, updating the standard, and do the actual accreditation survey on site. There is Accreditation Canada, or HSO, has more than 1,000 basically subject matter expert. We are in 40 different countries, and we have 14 locations that are using our standard, both in Canada and outside of Canada. So we have a lot of experience. And when we talked about healthcare setting, it's exactly what we look at. We look at healthcare setting, and medication management is part of an element of the setting. And towards the end of my presentation, I'll tell you that there's a standard that get assessed if we go and assess a community pharmacy or hospital pharmacy, a clinic that provides care. So the standard basically are there to increase consumer confidence. They're focusing on all these key elements on patient safety, outcome and experience, workforce safety and experience, efficiency, cost saving, reduction of risk and harm, and global mobilization of evidence and benchmarking. And as moving forward, the benchmarking is how do you know you're doing a good job? in whatever you're doing? You have been able to compare some of the safety practice with other organizations to be able to see that you are basically doing a good job at some point? This is the process to create the standard. It's important to understand this is not something that I wrote in my garage and I said, we're going to implement these standards. Basically, it goes for public consultations. So it starts with, we will notify that we are updating the standard. We create a group, a working group that will look at the standard. And the working group is basically our people that are academic, user. We have two patients, two patients representative on this that have live experience with medication issues. We come up with a consensus together. Then we're going to public review, and our current updated medication management standard are going for public review next week and give you a chance, and they go public. So you can distribute them and anybody can comment. It comes back to us at the medication management committee to review and address the standard. And the standards are written to improve the quality of the care. And it's important to differentiate between the regulatory body, who's a basically enforcement of standard, to improvement, quality improvement, which is basically improving the quality of the care. Sometimes they do overlap, but they're slightly different. And I can say this with confidence because I used to be many years ago the president of the Ontario College of Pharmacists, which I was more the regulatory process. And now I am now on the other side of it. So it's important to understand. And they get approved. They also get maintained on a regular basis within a cycle to make sure they remain relevant. The current medication management standard that are going out for review are based on these 11 different chapters. And I will go with some of these chapters to give you a flavor of what it looks like. So the first one is planning the medication management program, selecting and procuring medications, labeling and packaging medications, storing the medications, accessing client and medication information, which was really shared by Sarah, how important that is, and Sarah and Susan, basically. Prescribing, ordering, specific medication protocol, dispensing medication, administering medication, and client monitoring, documenting, and the impact on the environment. So if we look at it from a medication management, it's all the key elements you need to integrate into your practice. And some of these might be relevant to a big tertiary care hospital. We can also make these relevant the way they are written to a community pharmacy that has a clinic. Some of the standards might not be applicable because they don't provide that level of service, but some of the essence behind the standard are applicable or wanted supposed to be applicable to all the environment. And I've done survey in sexually transmitted disease clinic. They had like 5 drugs they were giving out, and some of the standards did apply, not all of them, where they were prescribed by a nurse practitioner. So you can assess some of these elements. So it goes from all the range from tertiary care hospital that do advanced care or the people that do very, very focused care. A flavor of them. So I'm giving you some of the flavors. The structure, you have like the chapter, planning the medication management program is the first chapters. And this, the organization leader and the interpersonal medication management committee implement medication management programs. So this is the subchapter, and then you have the standards underneath. And the first standard is basically, we need to maintain evidence-informed medication management policy and align with the current legislation and standard of practice. And if you notice, if you're basically a hospital, we expect that medication management does not belong to the pharmacy only, it belongs to the hospital. If you're a community pharmacy, it might be a small group within the pharmacy that look at this approach together. But so what we expect to see that there's some kind of oversight of the whole system. And it was very clearly identified that it's a system issue once you go and provide higher level of care as a pharmacist have been enforced or it's moving forward. And you have a few other examples here, but basically the leaders need to dedicate resources to support continuous quality improvement for the medication management standards. It means that you need to monitor the practice, going back to the concept that we want to make sure there's improvement in the system. It's a quality improvement initiative. Chapter 2, selecting and procuring medications. So the big chapter, the 2.2 is basically there will be a group that will review and maintain a process to make sure you select and you procure medication and from a safe manners. It's interesting, this one, if you belong to a group purchasing organization like some hospitals do, some of this could be delegated at a higher level. If you belong to a chain of drugstores, it could be the chain of drugstore that take on this responsibility. But yet the person that's working with that pharmacy still has to ensure that's taking place, that the drug are procured in a safe, efficient manners. So this is the 2.2.1 is basically the actual standard. One of the standard we have integrated in the new medication management, and there's a whole chapter on it, but basically any management or proclamation should be considering the environment and the impact on the environment. And here's the structure of the standard. So 2.2.1 is the actual standard, and you have the guidelines. You don't yet get assessed on a guideline. It's just to help the surveyors when we go on site to understand what the standard means, what it can look like. But this is, you don't get assessed on the guidelines, you get assessed on the actual standard to make sure that it meets the essence of the standards. Give you more example or different chapters. I'm not going to the chapters because it's a very long document, but storing medications. In hospital or institutions, sometimes patients bring their own meds. So there needs to be a structured way they will bring their own med and it's been stored properly. In Canada, cannabis is legalized as for recreational use, for medical use as well. And there's a whole legislation around the use of cannabis in Canada. Therefore, we need to integrate this in our standard because if you're using medical cannabis, you need to be able to store it properly. And actually, as a footnote, it smells a lot. So it needs to be in a secure area because it's a controlled substance. So to be something that's sealable because it can affect, it can smell. So that's just a joke. But the point is, this is the integration of the standard that we'll look at as from a story. It's just as an example. Medication-specific protocol. We realize at the technical committee, there's some group of drugs that are more important or you have some issues. And in Canada, you probably have heard in the US as well, there is an opioid crisis, basically. There's more people in Ontario, when I was president of the college, they were dying from opioid overdose and they were dying from car accident. So we need to have system in place from a healthcare system to make sure that there's a strong monitoring of controlled substance. So again, you have the standard group or subchapter that they needs to maintain controlled substance management program, which again 7.11 means part of this chapter. We want it to be a procedure for monitoring the ordering, usage, and waste and disposal of controlled substance, a program to prevent and manage diversion of controlled substance, which is 7.12, procedures for intervening when there's a controlled substance diversion, and continuous learning about make sure that everybody understand how the diversion could be detected. So it's a very good example of a substandard and a group of standards that address some of our key issues from a North American perspective. And then again, all of these do have some guidelines that describe more in detail what we expect to see. Again, you get assessed on the standard, but not on the guideline. Going to this medication-specific protocol, we have the issue of a complementary alternative medicine. So we have to be respectful of what the patients brings in or what they are using, but yet we have to make sure it's safe from a clinical perspective. So there needs to be some work being done. Cannot be ignored because some of them could have significant impact on patient care as well. Antimicrobial stewardship. We're going to go talk about this. It's a make sure that from a global health system point of view, we want to make sure the optimal use of antibiotics. Again, a good example from a small community hospital or pharmacy clinic that allowed to prescribe antibiotics, they need to have treatment guidelines that comes from the bigger organization from antimicrobial stewardship. That could meet the standard in that context. But if you have the big organization, you should have your own treatment guidelines and being monitoring them as well. So again, adaptable for different environment. Compounding is also high risk practice. So it needs to be safe compounding and they need to make sure they have the proper environment and the proper disposal of hazardous medication. So all the different, and just like some elements, not everything, but tells you a flavor of what type of standard we're looking at. And the new chapter that I've created is basically on the impact on the environment. So they say that the pharmacy is responsible for up to 20% of carbon emissions, like the production and the giving the patients the waste that we generate and the destruction of this. So again, the first standard on this one is about acetic gases because they are known to be very bad for the ozone layer, basically. And if you don't, it's not applicable. Everything you do should be considered the impact of the environment. The best example is the inhalers, the salbutamol inhalers. If you go to a hospital, if you're hospital focused, usually you get one in the you can get one in the ambulance when you get brought to the hospital. You get one in emerge. When the patient gets transferred to the ward, it gets lost. So you get, and the pharmacy dispenses another one. None of these inhaler has been used optimally, and technically they cannot be reused in another patient. They get wasted. So you have this thing has some effect on the ozone layers, or carbon emissions, if you want, and it gets wasted. So the approach is to come up with a process that would make sure the inhaler follows the patient all the way through, or to use inhaler with a lower carbon footprint altogether. Again, part of the environment, looking at packaging, selecting medication that don't have too much plastic in their packaging. How you return medication and use, in Canada, it's very common that most, actually all pharmacies would take back unused medications for proper destructions. It should be incinerated. Ontario and Quebec, I license both Ontario and Quebec, and it's by kind of legislation. So you have bring your own medication to the pharmacy for destruction, but it needs to be in place so it doesn't go to the landfill or to the sewer system. And we need to make sure that everybody gets trained on the impact on the environment. So when you look at this, and you just said that you're a pharmacy and I'm going, or an institution or hospital, I get assessed for a medication. You want to assess maybe from an accreditation point of view. You will look at the medication management because, of course, and I'm always says it's all about drugs, because if you don't know drugs, you cannot treat. Actually, drug and surgery are the mainstay of therapy, and there's social care as well. But without medication, you cannot do much. But also, you will be assessed on the whole system, and you'll be assessed on governance, leadership, whatever it's pertinent to your environment. And here you have the list of this different standard, client safety, and there's also so require safety practice, like opioid stewardship is one, antimicrobial stewardship, a medical device, workforce safety and well-being, health equity. So we look at the whole system. We just don't go in and we only look at the medication management system. We're going to look at how does it fit in within the global healthcare system altogether. And it's important to know this from a quality improvement point of view, because if you only look at one set of standard, you're probably missing the boat altogether. And mainly in Ontario, I think I've done probably 3 community pharmacy, and some of them are applicable, some of them are not, but some of them are applicable for community pharmacy that are providing care to make sure that they meet all the quality improvement initiative that could be in place. So this concludes my overview of the medication management system, the standards, and how they fit in with the big global picture. And I do think that they do fit well with the increased scope of practice as you're trying to do more. And it was very well identified and mentioned by Sarah that we need to be part of a healthcare system if we increase our care that we're providing. And the medication management standard within the HSO or Accreditation Canada is a tool to help you to achieve this altogether. So Andrew, I'm giving you back the floor.
Thanks, Dr. Rajit. That was great. A couple things for me that stood out. Obviously, we're really excited here at Accreditation Canada and HSO to have this standard updated. But a couple of things, small things that again stood out to me is the what you said early on about the difference between regulatory bodies and Accreditation Canada. That this standard and sort of what we do is really about quality improvement and patient care. And then that last screen, just to sort of highlight that screen of all the standards that we have at Accreditation Canada, that it sort of fits into a holistic program that really focuses on improving patient care for your clients. So it is question time. Obviously, if you have any questions, continue to sort of put them in. Our team is sort of sorting through and combining them together so we can obviously stay on time. I'm going to start with one for Sarah. With scope of practice expanding, how do we strike the right balance between increasing access and ensuring pharmacists are supported to provide safe, evidence-informed care?
Thanks, Andy. That's really an important question because while expanding access to care is a key piece of this puzzle, we also want to make sure that the public safety is always maintained, that we're doing so in, a careful, as in like actually taking care to ensure that pharmacists are adequately prepared, they have the right tools, they have the right education, they have the right practice environments in order to provide these skills in a safe, effective environment. And I think the other key, which I had highlighted in my presentation, is really that communication piece. Because if it stops at your pharmacy and no other provider in your healthcare, your patient, your circle of care is aware of the treatment you've received, of what's going on, I think that would be a significant issue. So I think having, I think there was one other question in the chat talking about the legislation. So first we have the regulations in place to clarify what is the scope, what is allowed, what's not allowed. So we have guidelines to build upon. We always need that foundation. Then we have a regulator in place to help to maintain that, take that regulation and bring it into real life, so that we can see how, we're able to put these, what's on paper and in legislation is how does that become patient care? It goes through the regulator to ensure that public safety piece is maintained. It also then it flows through to the pharmacy professional, ensuring that they have the right tools, the right knowledge, the right access to those documentation tools, for example, and really collaborating with that circle of care of the patient. And then we have the piece, of course, like that flows from both the regular and the healthcare providers, the patient piece. So that patient piece is very key, because as we talked about, it's the patient who is at risk when things go wrong, who may lack that critical access to care. So having patients as partners in this whole flow of information and the access to service, and also the feedback, which is really key, right? Because nothing can operate in a vacuum without some feedback mechanisms, without safety mechanisms, without ability to continue that information flow. Things risk being siloed, and that's when we run into problems. So I think this is where we see those three things constantly interacting. And I think we need to have both the careful planning, the regular check-ins, like build it, have good foundations that we can build upon. We already have a lot of very strong foundations in Canada, in terms of regulation, in terms of practice, in terms of education. We're quite fortunate to have such consistency of education across the country. So I think we build on these things that are there already. We have a lot of very competent and knowledgeable healthcare providers, and we have this gap that needs to be filled. So by ensuring those three things are working well together and communication is flowing, and there's a mechanism for feedback, I think that's how we create a successful program that helps all those elements in that group, provide the care to the patient in a competent, caring, and safe way.
Yeah, to borrow a phrase from sort of, we're reaching the point in healthcare where it takes a team, right? And that team needs to have that good communication built into it. Susan, you had mentioned something in your presentation, a very small phrase, and I'm gonna sort of touch back on that, where you had said that your pharmacist knows you, and sort of building off of Sarah's sort of aspect, bringing the patient involved with that communication. Can you just comment a little bit farther, maybe on that aspect of being part of your healthcare journeys, or in the person you're advocating for, being part of their journey, being part of the conversation, having empowerment in that sort of in the situation?
Absolutely. So I'm lucky that I live very close to my local pharmacist, which is at my grocery store. So that's incredibly convenient. And I think many people have some prescription. There's a huge burden of chronic disease across the world. So we often interact with our pharmacist on a regular basis to get our prescriptions renewed. We also interact with our pharmacist to get, over-the-counter medication. So this is someone that we know, and that's someone that we trust. And I think that makes a huge difference. And even if we're going to a different pharmacy to get some over-the-counter medication, for example, we may not know this pharmacist, but I think we just generally trust pharmacists, that they have our best interests at heart and they want to help us. So I think that that's just an amazing foundation to start from, and it makes such a difference. And I know for myself and my family members who have to go to the pharmacy for various reasons, they have a relationship with that person. And so at times they've even said, so how did that XYZ situation, did that help you? Did the last thing I gave you, did that help your concern or your condition? So very much concerned that what they are offering and how they're able to help you is actually going to help you. So it makes such a huge difference, I think.
Yeah, I grew up in a small town, and I know even here in my community here in Ottawa that the pharmacist is down the street, and when you don't always pop in for major healthcare things. Sometimes you're popping in for small stuff, and you're just chatting about things to chat about. And I think that makes a big difference in relationships and trust and that sort of thing. All right, this one is to either Regis or Sarah, or both, if you both want to weigh in. Should the expanded scope of pharmacy practice be aligned with the legal framework for existing legislation? We touched on this really quickly with Sarah, but if you want to sort of touch on it again, and Regis, maybe you can weigh in on this one as well.
Sarah, you go first. You are still at the college. I'm not only at the college. You are.
Although actually I've just I recently left, but I've been I am quite familiar with a lot of the changes that are currently going on. It's, I think, yes, is the simple answer to that question, that everything does stem from usually legislative changes. There are some things that evolve, like that may come from education and needs. Like I think when healthcare needs are identified, they can certainly start there. But I think I believe what that question is asking about is, when there is usually when there's a practice change, while it can come through, various different channels, sometimes there's a need identified and it comes through that way. That is our way that we can move forward in a specific area, or it comes through a legislative change that then is, communicated, goes through regulation and the regulatory colleges to the healthcare practitioner with all as a means of filling that gap. So that is often, the major changes do require legislative support in order to usually sort of inform that authority or expanded scope.
Let me add to this, Sarah, basically. So I agree with you, but it's a healthcare system that's will also guide the change in practice, the scope of practice. Again, I'm practicing in Quebec right now. I have access to the lab tests. And if I prescribe a lab test, I'm not allowed to prescribe lab tests there. It will go into the system, so the physician knows automatically. I have it's called a DSQ, Dossier Santé Québec.
Right.
When I prescribe a drug, because I think 40% of the drug are prescribed by pharmacists in Quebec because there's such a shortage of physicians, which are basically renewal or extended scope type of things. So the point is, we have the system has been built to allow us to do more in the safest environment. Ontario, to my knowledge, doesn't have all these different, like having the knowledge of what they didn't dispense to the patient outside of your pharmacy makes a huge difference. And you can explain better. And having the lab test, last Saturday, I was explaining to a young man that he was upset because he has it's very clinical, a prostate infection. He could not find any bacteria in his urine. Well, that happens, so that's normal. And he was quite upset, and he was telling me about this. I said, let me look at your test. And yes, that happens, and it was very clinical. The point is, you have access to provide the care that you need, but the system needs to be aligned with this. To be able, it goes back to the key element that Sarah mentioned, communications. It all fits together. Once we have a centralized drug record, we don't have to bother the doctors with our adaptation that we do in community pharmacy. If I do adaptation in Quebec, which I'm allowed to do, to change the dose, and actually in the new scope, we'll be able to change drugs. Like if I'm managing the hemoglobin A1C of a patient in Quebec with the drug has been prescribed, I can pretty much like Ontario, increase the dose, lower the dose. And it goes to the system. So I don't need to send a fax to the doctor, I've done this. Because the doctor doesn't care. But if you don't have this electronic system to keep track of what's been happening, it makes it very difficult. And when you do this, so to me, it's the system also makes a huge difference. to enable these things. And probably by August, we'll be allowed to change the medication. So if I am managing diabetes and the metformin doesn't work, I'll be allowed to add the medication within my scope. So that, but the system, everybody will know that I've done it.
And I think many people probably envy that system that has that type of access to so that your circle of care has access to that information, you know, in a secure, confidential way as well. You know, there is a lot of variability across Canada in terms of what those systems look like. And unfortunately, provinces generally don't speak to each other. Provinces speak to each other. The systems don't necessarily integrate with each other. Sorry, that was that's sounding the wrong way. But you know, so that type of future integration would really be very helpful in terms of you know, having that the information available for patient care. Because I agree with you. You just said that sort of record is really
Guide the
key.
legislation as well. If you have this system, a healthcare system, going back to what you said, if you have the proper system, and then from a patient perspective, the other thing that's interesting in Quebec, the patient don't have access to a lab record. Yes, in Ontario, as a patient, I have access to my own lab record, which is kind of weird. I cannot. It's kind of weird. But right now in Ontario, if I go to any lab, pretty much, I can see my lab record, lab record, before the physician sees it, or at the same time.
Yeah.
Quebec doesn't allow that, which is kind of different. I think they should, but that's different things.
Yeah, I think there's several wish lists going on.
I'm going to throw this out. This is going to be in the same vein-ish, but it's going to shift things slightly. So this is to the whole group. Feel free to jump in, and then we'll sort of bounce around. Considering the global health impact of pharmacy practices, are there any sustainable models or interventions being followed internationally that can be considered adopting? So they're really sort of honing in on the environmental footprint, especially with regard to carbon emissions. So again, sort of comparing different areas globally, internationally is probably potentially within Canada.
So I can answer this one. First of all, our company is working on this, like the company I'm the vice president. But basically, the WHO came up with a document about the impact of the environment on healthcare. And there's an artist as well from the Netherlands that basically came up with a picture. And I wish actually, when we went to the Accreditation surveyors conference, it was shown 2 or 3 times of the impact of a mastectomy on the environment, like how the consumable that were used for a relatively simple surgery. Like mastectomy is not like it's still a significant surgery, but it's not like a heart surgery. So there is tools out there that exist about to increase awareness of the impact of what you're doing in the environment. Another good example is really to administer medications. So if they give you in a vial and the pharmacy has to prepare it into a syringe, all the waste, it's been shown that there's less carbon imprint if it's prepackaged in a syringe ready to administer to the patient. So another good example. Some company are focusing on that practice as well. So there's an example. Anesthetic gases, a lot of data on this one. This is why it came up as a standard, because there's a lot of data.
So do you want to weigh in?
So, Sarah, you want to add to this, or Susan?
No? Okay. Thank you. Sarah, as the scopes of practice evolve and sometimes overlap, how can pharmacist-led care be effectively integrated to enhance collaboration and continuity across the healthcare system?
Well, thank you for that question. I think that is probably one of the key things that you know, we've seen across all 3 presentations is what does this scope expansion look like, and how are they part of the changing landscape in healthcare? So I think some of those things I've touched upon already in terms of, you know, the systems, the patient, the education, the regulation, and those are all very key, you know, and the continuous quality improvement. But, you know, I think it is important also to see those opportunities for where we can help help that integration, whether it be across provinces, like we're talking the wish list of computerized systems. I think the other key piece is, we talked about places of practice. So as this is evolving, for example, hospital pharmacists, even within provinces, have different scope than a community pharmacist. But if that same hospital pharmacist were to walk across the street to a community pharmacy, what they would be able to do changes. So it's that sort of variability that sometimes, the more integration we can see in the system, the more continuity in terms of what care is provided by the healthcare provider. There may be overlap, but I think in a system where there is such a significant strain and potential gaps in care, that sometimes some built-in redundancy is a safety mechanism as well. I think it will be interesting to see where professions go in terms of what defines them as a unique profession versus what are the overlaps. I think there's always been some element of that in healthcare. Perhaps it's more now than it was before. But it'll be interesting to see. I don't have all the answers to that, where it's going to go. But I think that collaboration piece, some redundancy in the system that does have a lot of strain, is a good safety mechanism to have in place. But then also that communication and understanding of the roles of each of these specific providers, because I think they all have specialties as well. So areas that they have specific training in, specific competency, and so they have their focus, which fits into the broader care of the patient and the public.
Rajesh, Susan, do you want to weigh in?
So I want to win, but well, Susan, first of all, I just want to say, Susan, it's all about the patients. But I have another example to give. So go ahead. I'll talk after.
Thanks so much. And just in case people haven't seen it, it was earlier in the chat. I put a link to some research that was done here in Nova Scotia. It started in 2021, finished in 2023. So giving that sort of lessons learned over a few year period of how the expanded scope of pharmacists, how's it been going, and lessons learned and some suggestions for how to improve things in the future. Over to you.
So I want to go back to a recent survey I did last year in Quebec, where they redefined the role of the pharmacist in the hospital. It's hospital focused, okay? It's okay to be hospital focused. So they redefined the role of the pharmacist, the nurse, and the physicians. So they have redesigned in such a way that the nurse will call the pharmacist if it's a drug-related questions or an adjustment of dose. They will call the physicians to take care of a new diagnosis. Basically, they think completely new that's happening. It's not with them, like it's not the hemoglobin A1C, it's not the blood glucose, it's something. Then they will call physician to get the diagnosis. But basically, they have the pharmacist managing the drug. They have the nurse managing the patient. Like the nurse has a lot of different skill set. And they have the physician. And they did that because it was very interesting. It was some small community, and the physician did not want to be on call because they were bothered too much. Now it shifted the on-call to pharmacists for dosing adjustment. So then they were able to recruit more physicians to be doing the on-call for the institutions. So we all have an overlap scope, but we have different skill set. And as long as we get used properly, and it's all about patient care. What is it the patient needs right now? What's the most right? I cannot change your dressing, nor do I want to change your dressing because I'm a pharmacist. My hands are soft and clean, okay? Nurse can change the dressing. They know how to do it. So let's get them do the nursing stuff and let us do the medication stuff in collaborations. They can do medication stuff as well if they feel comfortable. And a comment that Sarah made, that's you always work within your comfort level. You don't ask a surgeon to manage diabetes. That's not what they do. You don't ask a pharmacist that's not comfortable managing diabetes. It's not because you have a scope of practice that you have to do everything. The key things is if you're not comfortable doing something, you don't do it, but you refer to someone that can do it for you. Like diabetes is, let's just say I'm not comfortable with birth control pills prescribing. I'm not quite comfortable. I'm not up to date, so I will ask them to go to a different pharmacy or to go talk to the physician, whatever it's available. As long as you don't, well, if it's emergency contraception, it's different. But the point is, you need to work within your scope and within your skill set as well. And that's what happened in medicine as well. Did that answer your questions, Andrew?
I think so. Not technically my questions. This is the
Okay.
audience question. I'm seeing a bunch of hearts and thumbs up flying up, so I think we're on the right track here. All right, to the group. This is a near and dear one for Canada. For those of you who are international, Canada has a wide variety of incredibly rural and densely packed urban. So how is the pharmacist scope expanding in underserved and or rural communities across Canada? Who wants to take this one to start? Regis, your mic's off, so let's start with you.
I'm laughing because where I work, it's an hour drive from Ottawa, and they don't have access. All physicians seem to be retiring together, so it's kind of remote, and you end up you almost have to optimize your scope because you do not have access to primary. They don't have as much access to primary healthcare. So I feel that in remote community, you have a significant role as a pharmacist because they don't have walk-in clinic that's easily available. If they go to emergency department for some stuff, they might like I remember I told the patient you might have like probably 24 hours. It's not urgent. I can help you out, or that's what you should be doing. So to me, it's even more important. And you can also use, there's also more telemedicine. And actually, Accreditation Canada has a whole standard on telemedicine as well, how to provide care remotely. So that's my answer. So maybe Susan, I'd like to hear because Nova Scotia also has a lot of remote community.
We do. We have a lot of rural parts of our province and would agree completely. If part of the reason why we're all here is to help patients and families, then we have to think about all the different ways that we can do that. And again, there are more probably pharmacists around than there are places to see a doctor. And you're right, not every place in rural Nova Scotia has walk-in clinics. In our capital city region, we have many of them, but they are also incredibly busy. And people can go to a walk-in clinic and be waiting for hours and hours and hours. So giving people options so that they can, we use the phrase, the right care at the right time and the right door. But that is so true, and not just words on a page. Having options for patients and families that are safe, that are trusted, and they can get the care that they need and let them get on with living their lives is just so important.
And the good example is UTI in women. UTI in women, if you go to the emergency department with this, you'll wait. It's just not an emergency. But most, actually in Ontario and Quebec, we're allowed to, Quebec has different rule for this, but you're allowed to prescribe for TI in women. It has a significant impact on the women, on the patients. And to me, that's a very simple one. Even the sore throat, getting a strep test is not that easy sometimes. But some pharmacies do it, not all pharmacy. The point is there's very basic stuff that can be done and to prevent unnecessary wait. That's not only the wait. It's like the doctor doesn't need to do this. It will not prescribe any test if you have a basic UTI in women.
And I think what you kind of focus on there are where are the opportunities, right? Where are the pieces that we can bridge care that is supported by evidence, that is supported by that competency, that understanding, that training, that builds upon training you may already have. So these are areas that you can make a significant impact on the lives of patients. So I think those are, when it comes to remote and rural settings, that you're right, pharmacists are often positioned in those environments to provide care, and maybe uniquely so depending on the setting. I think the other piece which I will highlight, as Regis was saying about with the telemedicine, that is an area that during the pandemic, we became more aware of how we may expand on that particular area to provide care when we may not have a actual person who can be there. There still may be access to that important advice, the triaging of issues, direction to treatment in areas that you may be able to not geographically travel to, but you may be able to still coordinate care from a distance. So I think identifying those opportunities, filling those gaps, and making use of the technology that allows us to reach out to a large geographical area more effectively is really important when we look at providing care in rural and remote areas.
So Stanley, this is an engaged group. So what are the group's thoughts? Someone wrote, what are the group's thoughts on telehealth services being offered by provinces 24/7, but having nurses provide medication-related support? I believe in BC and Alberta have pharmacists available for this telehealth team. It's the group's thought. Who wants to? Sarah, do you want to maybe lead this one?
Yeah, I'll lead because
So fair, yeah.
I lead and just put a comment there. These nurses follow protocols and they're doing triage. This is within their scope and they're able to do it. That's what I would say. What's maybe missing is the fact they might be, and actually in the pharmacy, they do get referred to us as a pharmacist in Quebec anyway, in Quebec. You get to go and see a pharmacist can take care of this. So they have a significant role to play to serve the population. How far they want to go, that's depends on their training that they get. So I'm not opposed to the concept at all. Having pharmacists like they do in BC might be better when it's a medication answer, but also they can go to their community pharmacy at that point.
Fair, yeah. Anyone else have any thoughts on that?
People often don't feel well at 2 a.m. You know, these things don't always happen during convenient business hours. So again, from a patient perspective, this is an option, and someone could help me or my family member outside of those business hours. That would be a huge benefit. But knowing, of course, that's also a resource issue. Not everyone wants to work the overnight shift. So lots of things to be sorted out. But again, patient perspective, that's an option. And I think telehealth has lots of pros and a few concerns about it. But I think we have shown through the pandemic how often we're able to sort through problems that we previously couldn't solve.
And I'm going to echo Susan's comment that after years of most of my professional career worked in an emergency department setting, and you're right, no one gets. It's rare to become ill or need medical attention at the most convenient time. We have office hours, but it doesn't necessarily fit into that. I think telehealth can be a very helpful resource. It gives somewhere for people to call. I think it's also important from resource management to with any medical resource. We, especially in Canada with publicly funded system, we do need to always ensure value of all the services that we are providing. I think there's been different models in different provinces that have looked at that, and like you just was mentioning how, yeah, you get referred to the community pharmacy. And I think that sort of resource management does look like it is thoughtful in terms of where those algorithms may lead you. So I think, having access to services is really important. Ensuring those services provide the care that they intend to is also important, so that, we can, as I said, thoughtfully and look at the way we are making decisions within the healthcare system and a publicly funded system with limited resources.
Wonderful. I'm so you just have to give me 2 seconds. David here wrote a comment, an international comment. I'm trying to determine if there's a question here, but I'm going to read it and then we'll jump from there. Back in Kenya, I work with a pediatric hospital which is JICA accredited, and we get reaccreditation review at intervals. I must appreciate the speakers of today as we share a lot around medication management and the use MMU systems, as well as the International Patient Safety Goals, ISPGs. Like high alert medications and the continuous effort in vigilance and continuous quality improvement and medication management regards. Okay, so it's a comment, but if anybody wants to, there was a number of acronyms around stuff. If anybody wants to expand.
I'm involved in the International Pharmaceutical Federation Hospital Pharmacy section, and we created the Basel statement. Actually, we were created maybe, oh my goodness, I'm so old, probably like 15 years ago. So it defines the minimum requirement you should have as a hospital pharmacy department, and that and actually, if you look at our accreditation standard, they kind of overlap significantly. So there is international, and GIC is the international from the Joint Commissions from the US. So.
Well, everybody, I think that's all of our questions. Thank you again. Those are great panel presentations. Thank you again to Dr. Rajesh, Sarah, and Susan. We greatly appreciate your time. To everybody who joined us, thank you again. Once again, just a reminder, we will be releasing a recording of this webinar in about a week's time. Thank you again for joining us in Accreditation Canada here for this webinar. We appreciate your time. Take care, everyone.